Then next, we're going to look at prioritizing hypotheses. And for this, the NCLEX wants to know, where do I start? And they can ask you that by saying, what is the client most likely experiencing? What is the client at highest risk for? What do I need to do first? Or which problem do I need to address first? We're going to jump to this COPD example. This client, 74-year-old male, comes in, worsening cough, yellow-green sputum production, dyspnea. He has a history of COPD. We're asked, the nurse should first address the client's blank, followed by the client's blank. And we have the same options in each of these two clauses in this sentence: nutritional status, respiratory status, suspected infection, and anxiety and restlessness. So our cues in this case have told us we have these 4 problems. Now we have to prioritize and decide what to address first, and in this case, what to address second. So first, the nutritional status. He hasn't been able to eat anything since yesterday morning. I'm not too concerned about this right now. Of course, if he hasn't been taking fluids, he could be dehydrated. But then when I look at my vital signs, his blood pressure is okay. His heart rate's a little bit high, but that could also be because he's short of breath. So I'm not going to put that in my top 2 for now. And then as far as his respiratory status, well, it's looking pretty bad. He's got a low pulse oximetry. He's breathing really quickly. That's like 1 breath every 2 seconds. And that's his chief complaint. He's coming in with this primary issue of being short of breath and coughing. And our vital signs tell us that this is problematic because he's not getting adequate oxygen. So that is definitely going to be one of my top 2 priority problems. Then my suspected infection. So we see here that we have a fever. He also has this yellow-green sputum, so this is definitely contributing to his respiratory problem. So yes, this seems to be the source of his respiratory issue, so I'm going to keep that in mind as potentially being one of my top 2 priorities. And then anxiety and restlessness. We talked about this a little bit in our first example, where someone who's short of breath is naturally going to feel anxious. I'm not going to get anywhere with them by trying to ask them to calm down. I need to fix the problem first. And in this case, it's very likely that he's anxious because he's short of breath. So I've narrowed it down to my top 2 things: the respiratory status, which is altered, and then the suspected infection, which is the cause of that problem. To decide what to do first, this is where I like to consider, if I'm going to do one thing and then walk away from that client, what should that one thing be? And so if we think about how we would address respiratory status, maybe that's by putting a nasal cannula on, or a simple face mask, or BiPAP if they need it. Comparing to suspected infection, where I'm going to address that by giving an antibiotic. Well, if I can only do one thing for them, if I hang an antibiotic and then walk away, that's going to take several hours to take effect, and that whole time they're going to be hypoxic. In this case, I'm going to prioritize my issue of airway and breathing, their respiratory status. I can first put them on a BiPAP or apply a nasal cannula, and then while that oxygenation is correcting itself, then I can give an antibiotic to address the underlying infection. Next, we're going to generate solutions. And in this 4th step, the NCLEX is going to ask you essentially, what can I do? Or which interventions are indicated or not indicated? Which actions help address or treat that problem you identified and then prioritized? Or which actions would worsen the problem and should be avoided? And I want to mention that this is going to depend very much on your understanding of the disease process, of your understanding of what those cues that you identified mean and which is the priority. So for example, shortness of breath. Again, if someone is short of breath because they have pneumonia, only antibiotics are going to help that. If someone is short of breath because they have congestive heart failure and they're fluid overloaded, they're going to require diuretics. Whereas if it's a pneumothorax, they're going to need a chest tube. So your answer to your step 4 is going to very much depend on your understanding of that disease process. And that's where we really recommend, after you answer a question, reviewing the explanation to really understand why you answered it correctly or incorrectly, so that you can apply that knowledge to future questions. So let's revisit here this client who came in with shortness of breath and the lower extremity edema. We're asked, for each potential intervention, click to specify whether the intervention is indicated or contraindicated for the care of the client. And so based on what we're seeing so far, She has a diagnosis of a deep vein thrombosis and a pulmonary embolism. And that makes sense. That explains why she has findings in both her lower extremity and her lungs, that she had a clot in her leg. It's causing that edema, that decreased venous return. It's also embolized and gone to her lungs, so she can't perfuse her lungs to pick up oxygenated blood. So before we even look at this set of options, we want to consider, what are we going to do to treat a pulmonary embolism? In this case, we already have orders for this client to be on a heparin infusion and then transition to warfarin. So we're giving a blood thinner and we are also giving oxygen support. We've applied a nasal cannula. So we're supporting her respiratory status while we are anticoagulating her with heparin. So those are the big things that we're doing. We also want to decrease any further embolization from that leg. So let's keep those in mind as we consider each one of these potential interventions. So to apply sequential compression devices, why do we do this? We do this in order to prevent deep vein thrombosis, right? It squeezes your calves, it increases your venous return, but now she already has a deep vein thrombosis. This has already been identified. So if we squeeze that extremity, that's just going to embolize more clots to her lungs. That is contraindicated. If this was a client who was just at risk for a DVT, it would be indicated, but she already has one, so it is contraindicated. Then placing her on bleeding precautions. I would say that's very important. She's getting heparin. There are many things that are going to cause bleeding in a client on heparin that would not in a different client. So we are going to place her on bleeding precautions. Instructing her on massage for pain relief. This is something that clients will come in and tell you. They'll say, I have had this pain and swelling in my leg, so I've been massaging it to try and make it feel better, but now I'm short of breath too. And that's because, just like our SCDs, it's embolizing clots. So this is contraindicated. Ambulating in the hallway 3 times daily as tolerated. So in this case, this client, remember, has this sharp chest pain whenever she's breathing. She has this sharp chest pain on inspiration. When clients have pain with breathing, they're going to take these really small, shallow breaths, and that has a risk of causing atelectasis, where you have collapse of the distal alveoli. One way to prevent that is by using incentive spirometry, which is actually our next option here, to keep them expanding those lungs and keep them ambulating. There is an old, outdated kind of school of thought where we thought that clients with DVT had to be on strict bed rest. It turns out that that actually did more harm than good, and you need to keep these clients walking. So yes, this is indicated. And then administering IV morphine for leg or chest pain, 7 to 10. If she's having such severe pain that she's not going to take deep breaths, again, that's going to create more problems for her. You might look at this and say, well, I thought someone with respiratory issues shouldn't get anything sedating or an opioid. And it's true that you don't want to over-sedate the respiratory system, but you don't want to do that because you don't want to cause atelectasis. In this case, her risk of atelectasis is because her pain is not allowing her to take deep breaths. So yes, we need to treat her pain, and an IV opioid is appropriate for this severe level of pain. And then ensuring protamine sulfate is stocked in case of bleeding. This requires your understanding that protamine sulfate is the antidote to heparin-induced bleeding. So yes, this needs to be stocked. And then obtaining a complete blood count. We always want to make sure anytime we're thinning the blood that we understand what that client's baseline hemoglobin, hematocrit, and platelet levels are, because we need to trend that over time in case there's any bleeding or in case she develops heparin-induced thrombocytopenia and her platelets start to rapidly drop. So yes, it is indicated when we're initiating a heparin drip to obtain a complete blood count.